Hello everyone, this video is about bronchiectasis. Bronchiectasis means abnormal and irreversible dilatation of bronchi, which is associated with obliteration of smaller bronchioles, also known as bronchiolitis obliterans. Here in this picture, you can appreciate the dilated bronchi. Bronchiectasis is a chronic obstructive lung disease. Now you may wonder, if there is dilation of bronchi, how come there be obstruction? It's because even though the bronchi are dilated, increased amount of mucus in the lumen will obstruct the airways. If you look at this picture, here is the normal airway. This is the lumen, bronchial wall lined by cells with cilia that expels out excess mucus from the lumen. In bronchiectasis, the bronchial wall is damaged. Cilia cannot function, hence the mucus are retained within the lumen, and that's how they obstruct the lumen. Also, even though the larger bronchi are dilated, smaller bronchioles are obliterated due to fibrosis, and they aid in the obstruction. Why are the bronchi dilated? It's due to destruction of smooth muscles and elastic tissues. Let's look at the etiological factors. 30% of the cases are idiopathic. Under congenital causes, first we have cystic fibrosis. In cystic fibrosis, there is defect in the chloride channels. Sodium and water are retained from the mucus and hence relatively drying out the mucus. This leads to formation of thick viscous mucus in the airway lumen. Cilia cannot expel out these thick mucus, hence due to defective mucociliary action, there is obstruction of airway. Slowly, bacteria start invading and destroy the bronchial walls, leading to bronchiectasis. Next, on the congenital causes, we have ciliary dysfunction syndromes such as primary ciliary dyskinesia and cartilaginous syndrome. Here is the normal 9+2 cilia pattern. Now the cilia is made up of many structures, but the important one is the dynein protein, which is shown here. The reason why it's important is because in primary ciliary dyskinesia, also known as immotile cilia syndrome, there is mutation in the dynein protein. This will cause defective ciliary motor function and hence retention of secretions, leading to bronchiectasis. 50% cases of primary ciliary dyskinesia have cartilaginous syndrome, which is characterized by situs inversus, bronchiectasis, and chronic sinusitis. The reason why there is situs inversus in cartilaginous syndrome is because during the process of development, our visceral organs, they rotate and finally come to lie in their normal anatomical position. This rotation is possible due to ciliary function. But if there is defect in the cilia, rotation does not take place. So the organs do not lie in their normal anatomical position. Why bronchiectasis and chronic sinusitis? It's because both bronchi and sinuses are lined by cilia. Lastly, under congenital causes, we have primary hypogammaglobulinemia. It's a state of primary immunodeficiency where the body cannot produce enough antibodies. This leads to infection and ultimately bronchiectasis. Under the acquired causes, we have primary tuberculosis, which is the most common cause. Measles and pertussis cause bronchiectasis, especially in infants. Pneumonia can also cause bronchiectasis. ABPA, or allergic bronchopulmonary aspergillosis, where there is hypersensitivity to the fungus Aspergillus fumigatus, can also cause bronchiectasis. Foreign body, bronchial tumors, and TB hilar lymphadenopathy usually cause localized bronchiectasis due to accumulation of mucus beyond the point of obstruction. Lastly, autoimmune diseases like rheumatoid arthritis and systemic lupus erythematosus can also cause bronchiectasis. Here are some morphological types of bronchiectasis. This is the normal. This is the cylindrical or tubular bronchiectasis, and it's the most common one. It occurs when the bronchus wall dilates uniformly. This is the varicose type, and this is cystic type, which is usually seen in cystic fibrosis. Now the bronchiectatic patients present with following symptoms: cough, which is productive, chronic, worse in the morning, and Postural type. What do you mean by postural type? Say this is the normal bronchus and below it is the dilated bronchus. The mucus are present here. When there is change in the posture, the gravity pulls the mucus into proximal normal bronchus. This irritates the bronchial walls and produces cough. Sputum is produced in copious amount. It is purulent and foul smelling due to anaerobic infection. There is fever, difficulty in breathing, pleurisy or pleuritic chest pain, hemoptysis, which sometimes is massive, and it's a medical emergency that requires bronchial artery embolization. You can call it massive hemoptysis when the production is more than 150 ml per hour or more than 500 ml per day. Children can present with weight loss and failure to thrive as well. In the signs, there is clubbing. Hypoxia in bronchiectasis causes vasodilation, especially at distal digits. This leads to soft tissue proliferation and clubbing. Halitosis or bad breath. Anemia occurs when our body tends to hide serum iron during chronic inflammation. It's called anemia of chronic disease. In auscultation, coarse crackles can be heard over the affected area, which is due to large amount of sputum. In advanced cases, there can be scarring leading to bronchial breathing. Under investigation, we can do hematological tests to look for anemia, increased ESR, and leukocytosis. Sputum examination by Gram stain or acid-fast bacillus stain to identify the organism and treat accordingly. Chest X-ray reveals tram-track shadows of thickened dilated bronchus, but these changes occur only in advanced cases. Here you can see the tram-track or tram-line shadows. HRCT is diagnostic, which reveals dilated airways. Saccharin test is done for screening, where a small pellet of saccharin is placed at anterior chamber of nose. Then we measure the time until it reaches the pharynx, at which point patient can taste it. Normal time is less than 20 minutes. If more, ciliary dysfunction is suspected. Under management, airflow obstruction is managed by inhaled bronchodilators and corticosteroids. Antibiotic therapy is given to treat the underlying infections. Chest physiotherapy can be done where the patient lies in a certain position where his affected lobe is uppermost. In this position, deep breathing and forced expiration helps to clear out sputum from the bronchus. Surgery is done when bronchiectasis is confined to single lobe or segment. In the prognosis, disease is progressive if the causes are ciliary dysfunction and cystic fibrosis. These can eventually cause respiratory failure. The prognosis is good if it's due to other causes. Here is a mnemonic for the complications of bronchiectasis. It's CS Hero. C stands for cor pulmonale, S for septicemia, H for hypoproteinemia, E stands for empyema or lung abscess, R is for respiratory failure, and O stands for other infections. So that's it for bronchiectasis. Thank you.